Now let's look at our first case study, nursing admission assessment. We looked at the nursing admission assessment case study in the first lecture in this unit and reference it here in this unit in describing the affinity diagram tool for root cause analysis. Let's review what we said. Hospital had 11 nursing admission assessment forms being used on its med-surg unit, including 2 which were automated, that were required to be completed for every patient. The 9 manual forms took 90 minutes to complete, and the 2 automated forms took 75 minutes to complete. Nurses wanted to eliminate the automated forms. All 11 forms and their content were listed on a spreadsheet and compared. Many duplications were identified, including that approximately 80% of the content in the 9 manual forms were duplicated on the 2 automated forms. Also identified were data elements rarely captured and data elements rarely used. A study was also conducted of consistency across the 11 different forms where data elements were duplicated, with a significant level of inconsistency identified in certain data elements. A formal evaluation of whether these data elements were actually needed and how they were defined was conducted with both nurse and physician reviewers. Upon conclusion of the study, a set of nursing admission assessment data elements were identified and used to create a single automated template. After training and process improvement, including resequencing some of the data elements for improved collection, the template alone took 60 minutes to complete. We also observed in the last lecture in talking about this case study that a starting point for this workflow may be nursing admission assessment, or it may be patient admission, depending on how the hospital has structured its patient registration and admission process. Increasingly, registering a patient for an admission to a hospital is either initiated via an emergency department visit in which a patient is registered with demographics and insurance data being collected after the patient is stabilized, or via a physician order for an elective admission, in which case certain demographic information is supplied through the order and potentially the physician's EHR, and any additional insurance and other information, such as an advance directive, is collected often via phone or a form mailed to the patient. We further noted that the ending point for the nursing admission assessment is nursing diagnosis, and related how nurses might use a nursing terminology system to achieve semantic interoperability. Diagnoses nurses may identify as a result of their admission assessment may include such as anxiety, pain, difficulty sleeping, disorientation, and high risk for infection due to underlying medical diagnosis, etc. In fact, any nursing process has 5 phases. First, an assessment phase, second, a diagnosing phase, third, a planning phase, fourth, implementing phase, and last or fifth, evaluation phase. The diagnosing phase feeds directly into the planning phase, where the diagnoses determine actions the nurse must take. These actions are documented in a formal nursing plan and then implemented. For example, if the patient is disoriented, the patient is at risk for falling and would need guardrails on the bed and perhaps assistance in getting up and walking around if this is permitted. Certain medical diagnoses also lend themselves to risk for infection, where patients may need a single room with an anteroom, where all visitors are required to use a mask or even to be gowned. Part of the planning phase for the nursing process is to work with the patient and family caretaker to develop goals relating to each diagnosis. These are very specific, such as pain at discharge following hip replacement surgery will be lessened to a 3 on a pain severity scale from a 7 on admission, and further lessened to 0 or 1 following 6 weeks of physical therapy. If goals are not met, theoretically, the nurse must work further with the patient. And I say theoretically here because hospital nurses rarely have the opportunity to work with a discharged patient. So with respect to the nursing admission assessment case study, some questions that may arise include, we observed that many hospitals are integrating the registration process into the nursing admission process. Assuming that this is the case in this hospital and an elective admission requires completion of registration prior to admission, but an admission via the ED might be incomplete with alerts from the IT system as to what is to be completed, how would this be illustrated on a process map? We also noted that the affinity diagram was used to identify what data were collected and where there was duplication across the 11 forms. We also noted that a formal evaluation of whether these data elements were actually needed and how they were defined was conducted with both nurse and physician reviewers. How do you think this evaluation was actually performed? How would you have specifically performed this evaluation? Take a moment now to think about these questions and document your answers. So our first question was, we observed that many hospitals are integrating the registration process into the nursing admission process. Assuming that this is the case in this hospital and an elective admission requires completion of registration prior to admission, but an admission via the ED might be incomplete with alerts from the IT system as to what is to be completed, how would this be illustrated on a process map? Remember in answering that one size does not fit all. The primary answer, however, relates to decision making about how the patient is admitted, which should be documented via a decision symbol. In this case, the decision symbol illustrates the two paths, with the one via ED having the added steps of the alert that admission data is incomplete and the RN completing it. Note, however, that this assumes that somewhere prior to the patient arriving at the hospital, the patient has been cleared for the admission. If this was a 2B chart, I would keep it this way because it starts with nursing admission. But if it was an as-is chart, I would suspect there could be some issues with how the elective admission actually occurs that is either in another map or should be on this map as well. With respect to this second question, we noted that the affinity diagram was used to identify what data were collected and where there was duplication across the 11 forms. We also noted that a formal evaluation of whether these data elements were actually needed and how they were defined was conducted with both nurse and physician reviewers. So our questions were, how do you think this evaluation was performed, and how would you have specifically performed this evaluation? Knowing hospitals well, I suspect that the nurses and physicians looked at the affinity diagram and simply checked off whether or not they thought the data were needed and offered the most common definition. A better, though albeit more lengthy, evaluation would have been to create a column for documenting specifically what each data element was used for, such as to define a nursing goal, to assist medication reconciliation, to alert a physician of the potential for a sleeping medication needed, etc. And perhaps another column for the desired definition of that data element, and a third additional column for the authority, ideally a specific reference that supplies the definition. These definitions and their authority should become part of the metadata for the information system processing the nurse assessment data. Some EHR vendors have taken these steps for their systems, others have not.